Hello. So this is our last MEC Minute for 2018, and I thought this month we'll end the year with a discussion regarding some geriatrics, clinical conditions, as well as a discussion about geriatrics and the normal physiologic changes that come with age. Today we're going to talk about what is aging. We're going to talk about some of the physiologic changes of aging, and then for the last half of this discussion, we'll talk about a few specific conditions, particularly those things that you may see this time of year, such as a complaint of altered level of consciousness. We'll talk a bit about dementia versus delirium and what's the difference. We'll talk about syncope and how we're going to evaluate patients who are older and who have episodes of syncope or passing out. And then I'm going to spend a slide or two just to talk about geriatric trauma triage criteria, contrasting the older patient population versus regular adults in terms of the state trauma triage guidelines. So we'll start with those normal changes of aging. Aging is not a disease, it's a physiologic process. It's something that happens to our bodies as we get older. It occurs at different rates among individuals, so some people age differently than others. Aging itself generally does not cause symptoms. We may not like the way we look in the mirror, but it doesn't give us physical symptoms. But illnesses and injuries associated with injury or with aging do have symptoms. As we get older, mortality rates increase, so the older we get, the more likely we are to die. As we age, we also become more vulnerable to disease. We also are more likely to suffer significant adverse effects if we suffer injuries. And our bodies as a whole have a decreased ability to adapt to stress. So if you take the same physical stress and subject a 30-year-old to that stress and subject an 80-year-old to the same stress, whether it's an injury or an illness, the 80-year-old is not going to recover as quickly, is not going to be able to adapt to that stress, and is more likely to die or succumb to that condition. So aging itself is influenced by four things. It's influenced by genetics. That's what we're given by our parents. That's the genes we have to work with. So some patients have increased propensity for certain diseases based on their genetics. Our aging process is also determined in part by our physiology, whether we are obese versus not obese, whether we are fit and conditioned versus unfit and unconditioned. So the physiology of our body is important in terms of how we age. Lifestyle makes a difference. So if you smoke, if you consume alcohol, if you engage in other practices that are unhealthy, you will most likely age faster than somebody who doesn't participate in these activities. And I think tobacco use is the easiest example of someone who seems to age faster than someone who does not smoke. And then socioeconomics are also an important part of aging. People of the lower socioeconomic classes generally do not have as healthy a lifestyle. They may not have as easy an access to health care, so they may age more quickly than patients or people who are of the higher level of in terms of income and life circumstances. I think we've all seen patients who we look at them and say they sure look like an old 50-year-old, or they sure look like a young 80-year-old. So I think we all have an idea of how our aging process is influenced by our genetics, physiology, lifestyle, and socioeconomic status. So just some examples contrasting a 75-year-old to a 30-year-old. A 75-year-old has a brain that weighs 92% of what they may have had at age 30. In other words, they've lost about 8% of the brain weight. Our body metabolism slows down, so a 75-year-old's metabolic rate is about 16% slower than that of a 30-year-old. They have less of a caloric need. Their energy production internally is lower. Kidney function in the elderly diminishes, so a 75-year-old generally has a kidney function that's 30% less than a 30-year-old, or when they were 30-year-old. the kidney is important, and this reduction of kidney function is important because a lot of what we do is dependent on the kidneys working properly. Medication metabolism, our ability to tolerate certain medications, our ability to clear certain medications, the kidney's ability to respond to stress such as dehydration or other adverse processes is all reduced because of this reduction in kidney function. And then our breathing capacity can drop by as much as 57% as a 75-year-old versus a 30-year-old. And this is without any influence of tobacco. So if you're looking at a non-smoker at age 75 having 57% of the capacity as when they were a 30-year-old in terms of their lung capacity, just think what it's like if you add chronic obstructive pulmonary disease on top of that. So the bottom line is, as we age, we're not the people we once were. This is just a graph to show some of the changes that occur with aging. So looking at specific systems of our body and what happens with aging, we'll talk about the skin, body composition, musculoskeletal system, and so on. From the skin perspective, the skin is much more easily damaged. It's not as resilient. It's very easy to tear. I know you've seen patients in the past who have mild shearing injuries to the skin, and they have those very thin flaps of skin which essentially are not suturable. They're too thin, but the skin is very brittle, easily to damage. Once the skin is damaged, it takes more time for it to heal. If the skin is injured, it is less likely to develop an appropriate inflammatory response, so that if there's an injury to a body part, let's say there's an abrasion and some germs are introduced into the skin may be less able to respond and develop inflammation in order to fight off any infections, so they may be more susceptible to developing infections in that area. And then the skin also loses some of its ability to sense pain and pressure, which is why the elderly often will develop pressure sores if we don't actively turn them, because they may not sense that there's irritation or damage being done to the skin by them laying in a certain position. So they may stay in that position and develop pressure sores as part of the process. I think all of us are aware that we just don't maintain that young, fit body that we had as younger folks. Just ask Pierce Brosnan. I mean, as we age, our percentage of body fat tends to go up. In this table, the average percentage of body fat goes from 20% in a 25-year-old to 36% in a 70-year-old. Our cell mass seems to drop. That's particularly true with muscle. We tend to lose our lean muscle mass. And if you look at a lot of the older folks, they may not have much muscle mass in terms of their thighs and their legs. They may not be able to stand and walk well because they just don't have the muscle necessary to move about comfortably and safely. We all see vision changes. Some of these have to do with degeneration of the lens, so we tend to develop cataracts as we age. Some patients develop macular degeneration. The macula is the back part of the retina where light focuses, is focused by the lens, and that's where our most sharp vision is. So if the macula degenerates, our visual acuity will diminish. As we age, we tend to lose the ability to adapt to dark, so our vision in the dark may be less acute, less keen as if we were younger. We tend to lose our peripheral vision, so we may not be as aware of what's around us. As we age, we may also lose that ability to sense contrast between light and dark or shades of gray. So it may not be as easy to see what we're doing, and we may not be able to identify things that we need to identify to keep ourselves safe. And then we also lose accommodation. That's the ability to see things clearly if we look closely. So generally, anything over 4 feet from your eye is considered far vision. Anything less than that is near vision, and the lens cannot adapt because it becomes stiff, so that as we age, this stiff lens cannot accommodate to looking at things closely, which is why all of us end up with readers or reading glasses so that we can read the newspaper or magazine or the computer as we age. The special senses also take a hit. If you think about hearing and balance, the ears tend to have problems. As we age, we may lose some of the vestibular function. The vestibular function is the function of the ears that give us balance, so we can be balance impaired, which is in part why the elderly tend to fall more. We also tend to develop hearing loss called presbycusis. So we tend to lose higher frequency hearing. Some of us lose all frequencies of hearing, so we need to have hearing aids. But typically, as we age, we all lose that higher frequency hearing, and that's part of the normal aging process for the ear. We tend to have alterations in our smell, which can affect the elderly and their appetite. In addition, as we age, we tend to have more dental problems, and you have to have good teeth in order to eat well. So if you are edentulous or don't have your teeth, you may have trouble eating, or you may be stuck eating food that you find non-palatable. We tend to have some alterations in our taste. Taste is a very important component of our appetite, so if we lose taste, we may lose portion of our appetite, and that may contribute to the elderly not eating well and becoming malnourished. The elderly also tend to lose the ability to produce an adequate amount of saliva, so they tend to have a dry mouth, which can also be bothersome to them. From the perspective of the nervous system, we tend to have a decrease in the number of cells in our brain. The basal ganglia, which is the center portion of the brain involved with motor movements, learning, eye movements, thought, and problem-solving abilities, as well as emotion. Those areas, basal ganglia, tend to shrink, which can affect all of these functions in which it's involved. The brain itself tends to have a reduction in dopamine. Dopamine is one of the neurotransmitters in the brain. If dopamine is reduced, we tend to have stiffer muscles. Parkinson's disease is an example. Patients with Parkinson's disease tend to have deficiencies of dopamine in the brain, which is why a lot of the medicines we use for Parkinson's disease are intended to increase the amount of dopamine in the brain. So patients with the drop in dopamine in their brain can become more stiff and have more motor abnormalities, and they are more likely to have problems with tripping, falling, and ambulating. Any elderly patient tends to lose their step height, meaning as they ambulate, they tend not to lift their foot or feet as high as they would as a younger person, so their gait involves steps that may be shorter or steps that are not as high as usual, and they're more likely to trip. With the nervous system, we also can have increased in our reaction time. So if something happens and we need to protect ourselves, we may not react fast enough. So elderly are more likely to get hurt simply because they can't react quickly enough to a threatening event. And then peripherally, our peripheral nerves also seem to take a hit. We tend to lose sensation of vibration and position sense. Vibration sense and position sense are important in terms of knowing where your feet are, knowing your body position so you can maintain balance, and so that you can determine where to put your foot down. If you think about everybody as they age, losing some of these problems, and then you throw on top of that complications of diseases such as diabetes, where you develop neuropathy in your feet. Neuropathy only makes these peripheral issues worse, so diabetics are more likely to have trouble with position sense and vibration sense. They may fall. They're also, because of their loss of sensation, are more likely to have injuries that go undiagnosed or unrecognized. An easy example is the diabetic foot with the ulcers and infections that we've all seen over the years as we treat our elderly patients. So those are some of the changes you'll see in the nervous system. In the musculoskeletal system, we tend to lose muscle mass, as I mentioned, in life. So looking at our third versus eighth decade of life, 20s versus 70s, there's about a 30% loss in muscle mass. If you want to be correct, it's called sarcopenia. I never use that word. I just tell patients they're losing muscle mass. The musculoskeletal system also takes a hit in terms of arthritis and degenerative changes. So you'll see changes in the spine, knees, and some areas of the feet because of wear and tear just from weight bearing. You can also see osteoarthritis or degenerative arthritis due to repeated injuries and strains, such as the joints in the fingers and the wrists and hands. Women more than men are more likely to develop osteopenia or osteoporosis, meaning thinning of the bone. 80% of the women who are over age 65 tend to have some loss of bone mass. So loss of bone mass is osteopenia. When it gets bad enough, it becomes osteoporosis. Decreased activity can contribute to this because the muscles stay strong if they're stressed by activity, walking, working, and so on. Dietary calcium can be an issue in terms of if you don't take enough dietary calcium, you can have weakening of the bones. And then estrogen is an important part of maintaining adequate bone mass, particularly in women. So as women go through menopause, they can have loss of bone mass as part of their aging process. I think we all recognize that if a patient has osteopenia or osteoporosis, they're at higher risk for fracture. In the elderly, the most common areas fractured are the spine, hip, and the wrist. Spine fracture typically is a compression fracture. It can occur spontaneously, meaning it can just happen because the spinal or the vertebral bone is just becomes too weak from the osteoporosis and collapses on itself. Or you can develop a compression fracture from a fall. We have seen hip fractures in patients who fall. Hip fractures must be treated. There's about a 25% fatality rate in the first year after a hip fracture, so it is not a benign orthopedic surgical problem. And then we see wrist fractures commonly in the elderly when they trip and fall and they put their arm out in an outstretched position to try to protect themselves. They commonly will fracture the wrist, often with displacement that requires manipulation by an orthopedist. I mentioned earlier some changes in our kidney function. I think as an emergency physician, one of the most important changes I see related to aging, it has to do with kidney function because as patients age, the kidney function deteriorates. We often cannot give them intravenous X-ray dye for CT because their kidney function is too poor to allow it. If we give them contrast, it may damage the kidneys further, whereas the contrast is perfectly safe in somebody who's got normal kidney function. Sometimes we have no choice and have to give the patient intravenous contrast, but we then follow their kidney function to make sure that it does well. But the kidney's ability to function drops by, ability to filter drops by 30 to 46%, and the kidney blood flow itself seems to drop by about 50%. The kidneys at that age are more susceptible to adverse effects of illnesses and injuries such as diabetes or hypertension. The kidneys can also take a shot and have acute kidney injury if the patient develops hypotension, such as due to sepsis or dehydration or hemorrhage. And then another important thing about the kidneys is they tend to clear a lot of medication. So if you have impaired kidney function, you may need to adjust the medication doses for the patients. Some of the anticoagulants, some of the antibiotics are cleared by the kidneys, so if the patient has impaired kidney function, we give them a lower dose or a dosing schedule that is less frequent than if the kidney function was normal. So we have to be aware of that. Also, the kidneys at this age tend to be less tolerant of adverse effects of medications. So certain medications such as anti-inflammatories can damage the kidneys if they're not working well, and we may need to avoid those medications. As an example, if a patient has poor kidney function, we generally do not give them anti-inflammatory medicines like naproxen or ibuprofen because they've been shown to adversely affect the kidney if it's not functioning normally. GI changes, the GI tract may have less motility, meaning it may not move things through as quickly, which is a reason a lot of the elderly are constipated. The GI tract may not absorb blood or absorb food and nutrition as well, which could result in malnutrition in patients or vitamin deficiencies in patients. And it also may affect the ability of the body to absorb certain oral medications. So the GI tract does have some changes. From the vascular perspective, the vascular smooth muscle that within the arteries becomes thickened and also becomes more stiff because of deposition of collagen and other materials, and the elastic components of the vascular system may become less elastic, they may break down. All this can result in weakening of the blood vessels, therefore increasing the risk for things such as aneurysm and dissection. We also will see some atherosclerotic changes where there's narrowing of the blood vessels. The bottom line is the net result for vascular changes is increased vascular stiffness, blockage of arteries, and resulting from that is increased risk for aortic disease, coronary artery disease, or peripheral vascular disease. That's why we see in the elderly increased risk for aneurysms and dissections, increased risk for myocardial infarction, and increased risk for peripheral vascular disease, threatening the viability of the extremities, particularly the lower extremities and the legs. And that risk is increased if the patient smokes. From the perspective of the heart function itself, the ability of the heart to squeeze and contract generally remains unchanged as we age, unless there's some overlying injury to the heart, such as a myocardial infarction, or unchanged or changes in the heart secondary to hypertension that is or that cannot be avoided because of patients' noncompliance with medications or severe disease. The heart valves themselves tend to become thicker and stiffer in age, which is why we tend to see more valvular disease in the elderly. If somebody has some underlying valvular problems to begin with, they can be accentuated by these aging changes. It's why we tend to see more people with aortic stenosis requiring aortic valve replacement, or for patients who have a history of rheumatic heart disease, which is actually something we rarely see now, whereas 40 years ago it was very common. But people with rheumatic heart disease can have trouble with the mitral valve and require mitral valve replacement. From the blood pressure perspective, as we age, the systolic pressure tends to go up a little bit, but then stabilizes at age 75. The diastolic pressure tends to stabilize at around 65, and in some people, particularly in women, it may decline a little bit with we age. Because of our changes with age, the heart may have a decreased ability to compensate for stress or compensate for impaired left ventricular function. This is particularly true because the heart's ability to increase its heart rate to stress is limited. So the accepted maximal heart rate for an older patient is much lower than what we'd accept as a maximal heart rate for a younger person. So if you have a patient who has coronary artery disease or has left ventricular dysfunction because of coronary artery disease, hypertension, or other problems, if they're under stress, they may not be able to increase their stroke rate and cardiac output necessary because they simply can't increase their heart rate. So we also see in the heart some complications related to other illnesses that can have an adverse effect on the heart, such as coronary artery disease, hypertension, diabetes, those things that can cause cardiac problems to begin with. And then we add the changes that come with age on top of that, and patients just don't do as well. From the respiratory perspective, we will see that the lungs and the airways themselves become less elastic, just like our blood vessels, and become more rigid with age. We will see changes in our chest structure that are musculoskeletal because of osteoporosis that can alter the size and the shape of the chest cavity. If the patient has a history of chronic lung disease, you'll also see changes in the chest cavity as well. Think of the little old ladies who tend to have the humped over backs. They have changes in their chest size and dimensions, which can result in impaired respiration if they become under stress. As we get older, our vital capacity, our ability to maximally inhale and exhale goes down. We can also see changes that come with chronic lung disease that increase our respiratory abnormalities. So patients with COPD or pulmonary fibrosis have underlying lung disease to begin with, and then you throw on top of that the other changes that come with age, such as change in the chest dimensions and so on. It can only aggravate the symptoms related to the COPD and the pulmonary fibrosis. From the urinary perspective, the bladder of an older person tends to have less capacity than a young person. I was able to find that in an elderly person, the capacity of the bladder is about 250 cc's, whereas in a young adult, it tends to be 600 cc's. And sometimes you can have as much as 100 cc's or 100 milliliters of residual urine after voiding, meaning the patient is not able to fully empty the bladder when they do urinate. This is particularly true in men who have a large prostate that may obstruct urine flow. It can also happen in women if they're suffering adverse effects of medications. Some medications that the patients may be on can inhibit the bladder's ability to empty or void. The muscle just doesn't contract as well. We also see something called a reduction in the micturition reflex. Micturition is the passing of urine, and it happens, it's this reflex as the bladder feels full, the patient then, or the person then goes and empties their bladder. In a younger person, you start to feel that need to go to the bathroom when the bladder is about halfway full. But in older adults, the bladder may almost at capacity before the patient gets the sensation that they have to void, and this can result in incontinence, accidents, and so on. It can also result in patients developing urinary retention, which may require placement of a Foley catheter. The last thing I want to talk about is changes in our body as we age. It has to do with the immunity system or the immune system. Our immunity is impaired as we get older, and our ability to respond to infection is diminished. We have an impaired inflammatory response. We have impairment of other symptoms that can increase our risk of infection. So if we have trouble swallowing, if we have trouble with our airways, we have an increased risk of aspiration and aspiration pneumonia. If we have trouble with emptying our bladder, like I mentioned on the previous slide, we can develop a urinary tract infection secondary to chronic urinary retention. And some chronic illnesses such as diabetes can affect our immune system. That's over and above the changes that we see as we age anyway. And certain other medications such as steroids and immunosuppressants can reduce our inflammatory response. So steroids are immunosuppressants, but there are other immunosuppressants out there such as methotrexate and all the other chemotherapy drugs that patients may be on because of malignancy or leukemia or rheumatoid arthritis or some other chronic problem that requires an immunosuppressant. Another thing I think we should all be aware of is in the elderly, they may not develop the typical symptoms of infection that we might expect to see. Fever is one of them. The elderly tend not to develop much of a fever. They can, but you can take two patients, one elderly, one young, both have the same infection, perhaps of the same severity, and the younger person will have more likely to have a tachycardia, more likely to have a fever, and other typical findings that we'd expect to see in somebody who's got an active infection. I'd like to talk briefly about a couple illnesses in particular that we see in the elderly. I'm not trying to go through all the illnesses related to getting older, but there's a couple things I'd like to talk about. One of them has to do with altered level of consciousness. We see this a lot. Something's just not right about mom. So what's been happening with mom over the past couple of days? And in this circumstance, we usually think about common problems that are presenting in an unusual way. So when the patient comes in with altered level of consciousness, we think about things like myocardial infarction, which can have an adverse effect on mentation in the elderly. A stroke, I think that's one of the first things we think about. Strokes can result in altered level of consciousness. We also look for hidden infections, whether it's a urinary tract infection, pneumonia, or sepsis. Again, patients who are elderly may not have the typical inflammatory changes that we would see in infections such as fever, tachycardia, and so on, at least until it's kind of too late in the course of their illness. But sometimes patients come in, they have an acute altered level of consciousness, and it's a simple urinary tract infection. If we identify it and treat it, the patients go back to normal. We also have to think about medications. Medications can have common side effects, and sometimes those side effects are more pronounced in the elderly. Also, the current teaching is if you're on 6 or 7 medications, the chances are 2 of those medications in some way are interacting, possibly in a bad way. So older patients tend to be on more medications than younger. We always have to think about, is the patient's altered level of consciousness secondary to a medication or a group of medications that they're on? So it's also very important that if you have the chance, bring the medications with you to the hospital so we can check them out and verify that the patient's on the right medications. On a rare occasion, the medication is mislabeled. Sometimes the patients tend to combine medicines, or they may put 2 or 3 different medications in the same vial, and then it comes down to, are they taking the right medications at the right time in the right frequency. We also have to think about metabolic derangements such as hypoglycemia, hypothyroidism, and liver disease. I think we all think about hypoglycemia. I tell people we really can't do too many fingerstick blood sugars because you never know what you may find. We also have a significant amount of patients in the community with thyroid disease, and if their thyroid is underactive, they have hypothyroidism. It can be easily controlled with oral medications. However, if the patient has run out of their medications, hasn't taken them for 4 to 6 weeks, and they may be developing symptoms related to hypothyroidism, that can be life-threatening if not properly identified and treated. Liver disease is also a metabolic derangement or problem that can cause altered level of consciousness. So if the patient has end-stage liver disease and have developed hepatic encephalopathy, they can have an altered level of consciousness. That's where the blood ammonia level gets so high that the patients become sleepy, confused, and just outright altered, and they have to be treated with special medications. And the last thing we have to think about in altered level of consciousness in the elderly is drug and alcohol abuse. Alcohol use and abuse in the elderly is not uncommon, and we always have to think about somebody who is consuming alcohol and now has an altered level of consciousness, or had been consuming alcohol on a regular basis and is an alcoholic, and now for some reason they've abstained. Maybe they can't get to the store and buy more, or something happens and now they're in acute withdrawal. So always think about someone, even in the elderly, being under the influence of drugs or alcohol. I like to talk a little bit about dementia versus delirium. Dementia we see in patients, and it's a progressive disease that develops generally slowly over time. Dementia tends to affect mostly the memory. Dementia tends to have changes in the brain that we can identify either on autopsy or on imaging with MRI or CT, and generally dementia is irreversible. Delirium, though, is something different. Delirium tends to be an abrupt onset, meaning it happens in hours or days, and the changes in the patient's mentation can fluctuate from really bad to not so bad, but it tends to be acute. It mostly affects attention, meaning the patients really have disorganized thinking. They can't think about the current task. If you ask them a question, they may start to answer it, but then they zip off into a different area. Whereas patients with dementia, they may be confused, they may have memory problems, but they'll answer your questions and they tend to stay on task. Again, delirium tends to be a difference in terms of inattention. It often is reversible with treatment. So if you have a patient with acute delirium, if we identify the cause, whether it's an myocardial infarction or stroke or urine infection, if we treat that, patients get better. They tend to get back to baseline. The diagnosis for delirium is usually based upon observed behavior and abrupt cognitive changes. So family members or somebody says she was okay yesterday and today she's not. We sometimes have to think about, is there a life-threatening condition at play? Is it an MI? Is it a stroke? Is it hypoxia? Is it respiratory failure with carbon dioxide retention? Another thing to keep in mind is patients with dementia may develop acute delirium. So you could have a patient with chronic dementia who develops acute delirium. And so you have to keep that in mind. So the patient, really the key story to the patient there is the patient had a baseline level of dementia, and then they acutely became different. They acutely became agitated. They acutely became disorganized in their thinking. So you have to ask and dig out the details. Dementia is generally a progressive neurological disease. Alzheimer's is a common cause, but other things can cause dementia. Stroke and head trauma can do it. Think about the professional football players who've developed forms of dementia, secondary repetitive head injury and repetitive concussions. Delirium, however, tends to be caused by acute events such as infection, drug interactions, or sensitivity to medications. Certain metabolic problems such as dehydration, kidney failure, liver failure. Sometimes brain tumors can affect behavior and present as an acute delirium. So patient may have a brain tumor that has suddenly progressed to the point that now it's big enough that it's causing symptoms, or delirium could be related to recent head injury. Sometimes there are other physical problems, like I mentioned, COPD exacerbations, MI, and so on. And sometimes we'll see delirium in patients because of change in physical surroundings. This is particularly true in a demented patient. So the patient has dementia, they're used to the usual circumstances, they're in their home, they're used to where everything is, and now they're in the hospital because of some medical problem, and they're on the floor and their behavior changes. We'll sometimes call this sundowning, where patients who are normal or at baseline during the daytime, the sun goes down, they become confused and agitated, and that's really a kind of a form of acute delirium that can be managed. I'd like to move on just briefly to talk about syncope, because I think it's important you have a bit of an understanding about this, particularly in terms of what you can do in the field. Syncope is a common problem. We'll see it in young folks, we'll see it in teenagers, we'll also see it in adults, and we'll see it in the elderly. But if you see it in a teenager, the workup tends to be easier, tends to be more straightforward than what you would have to do for the elderly. So if you have a teenager who sees blood or donates blood and passes out, that's pretty straightforward. A patient who is an athlete and has an arrhythmia and passes out, that's fairly straightforward. Whereas in the elderly, you have to go through a whole list of ideas of what may be causing the problem. So in the elderly, the things that can cause syncope are, first off, those things that are mediated by the nervous system. You can think about the vasovagal episodes. The patient gets upset, something happens, they pass out, or they have some stimulation such as nausea and vomiting, and they develop bradycardia and temporarily pass out. Sometimes you'll see patients who cough so much or laugh so hard that they'll pass out. That's either post-tussive or post-cough syncope or laugh syncope. And then on rare occasions, we have patients who pass out after urination. That's called micturition syncope. There's a certain reflex, nerve reflex in place that goes with urination that can sometimes cause problems, and patients can become lightheaded and pass out. Not a common problem, but we do see it. I think we're all aware about orthostatic causes of syncope, such as hypovolemia or medications. Certain blood pressure medications can drop the blood pressure with standing. Patients who've had nausea, vomiting, and diarrhea and on Lasix or diuretics and not taking oral fluids well can develop hypovolemia and pass out when they stand up. But another one to think about from orthostatic perspective is Parkinson's disease. These patients sometimes can become lightheaded and pass out simply because of their Parkinson's disease, and their body is not able to accommodate the change in position, so they have to change position slowly. If they stand up too quickly, though, they may get lightheaded and passed out. There are also some cardiac causes that are structural in origin that we have to think about. I mentioned earlier aortic stenosis. Aortic stenosis is narrowing of the heart valve, the aortic valve. It's the last valve in the heart before the blood leaves the heart. It's the valve between the left ventricle and the aorta. If the diameter of that valve becomes too narrow, too small, then an adequate amount of blood cannot move through it. Patients who develop severe aortic stenosis can have syncope. Syncope associated with aortic stenosis is a time-critical event. It could be potentially life-threatening, and it could be life-ending if not correctly identified and treated. So typically, if patients have severe aortic stenosis at the point they've had a syncopal episode, that is considered one of the criteria for replacement of the valve. You can also think about aortic dissection as a cause of syncope. I think most of us can think of a patient or two that may have passed out at some point. It turns out to be an aortic dissection. If you have a patient on scene and they're complaining of severe chest pain or back pain that's between the scapulas, then think about, could this be aortic dissection, if you get called because they passed out. If you're worried about aortic dissection, I would suggest you get blood pressures on both arms, because if there's a significant difference, it could indicate that there's a dissection at play. Pulmonary embolism is a common problem. We see it frequently in the emergency department. Probably at Mount Carmel East, we diagnose it between 5 and 7 times a week. It requires anticoagulants. And one of the dangerous symptoms that can be related to PE is syncope. So I can think of a patient who was out of town, came back to town, was walking around a new house he was building, and he passed out. He did it a couple times. His wife brought him to the hospital. He had resting tachycardia, was a little hypoxic, and he had a large submassive pulmonary embolism and had to be admitted, and actually had to have fairly aggressive treatment to get rid of the clot. So when you have a patient who has an episode of syncope, think about pulmonary embolism, particularly for having chest or upper back pain. I think we all think about arrhythmias as a cause of syncope. We think about SVT, VTAC, and torsades also should be on our list. AFib, A-flutter, particularly if it's uncontrolled and acute onset, can cause syncope. If the heart rate's fast enough, the patient may not be able to move enough blood around. Their cardiac output may be diminished, and they can develop syncope with change of position. If the patient is truly hypotensive in the field with acute AFib or A-flutter, you may need to cardiovert them. We also think about sick sinus syndrome, where they have episodes of tachycardia and bradycardia, and we think about heart block. Both these conditions may require a pacemaker, so think about that as part of your differential. And the last thing I think you should think about for syncope has to do with those mimics that could cause syncope, but that's not really syncope, it's some other medical problem. TIA and stroke, I think we think of. Seizures are common. Sometimes migraine headaches can cause syncope symptoms. Panic attacks can cause syncope. Is it a panic attack or a vasovagal episode? Sometimes that's hard to tell, but you think of panic attacks. And then again, always think about hypoglycemia whenever you have any change in mental status, whether it's syncope or altered level of consciousness, acute delirium, and so on. So my next slide here, I just want to throw this up there just for your review, and I'm putting it up there to make a point. This has to do with all the different tests that we can do to evaluate for syncope and the likelihood that they'll help us make a diagnosis. So postural vital signs or orthostatic vital signs can help us 50% of the time or more. Tilt table test is commonly helpful. That's where the cardiologist has a patient lie on a table. They check their vital signs, and then they turn the table upright with the patient strapped to it, and they watch the patient's vital signs and see if they pass out. Telemetry, which is what we do in the emergency department, monitoring the heart activity. Holter monitor, which is a heart monitor that the patient wears for 24 to 48 hours and records their heart activity, looking for arrhythmias. EEG, brainwave test, CT brain, looking for structural abnormalities. And then these other tests, carotid studies, MRI of the brain, stress test, and cardiac cath. Those last four have a less than 1% chance of helping us make a diagnosis in terms of the cause of the syncope. So why do I mention this? Well, if you look at that, a lot of the things that make a difference, that actually those that are high yield assessments that we could do as part of a syncope workup, you can do, or you should be doing as an EMS provider. So 12-lead electrocardiogram, that would be looking for STEMI or any other arrhythmia abnormality. Orthostatic vital signs, that's the highest yield procedure that we can do in terms of assessing syncope. I think you should do that in the field. Cardiac monitoring is important as well. Does the patient have an arrhythmia at play? These first three items, the 12-lead orthostatics and cardiac monitoring, those are things that may change with time, which is why I think that you should do them in the field. I've had a couple patients over the past 2 years where it was information from EMS that helped the electrophysiologist, the cardiologist who does pacemakers, make a clinical decision. It was the EMS 12-lead or EMS rhythm strip that showed the rhythm abnormality that resulted in the patient getting a pacemaker or an AICD. And we had no test in the emergency department that was showing any abnormality, and the cardiologist was preparing to go down a long path of a workup for these patients. But once we showed the cardiologist the rhythm strip or information from EMS, he was able to make a decision. The patient got their device and went home probably 48 to 72 hours quicker than if they had to stay in the hospital for more of a workup. Blood sugar, again, that's something I think we should do for syncope. Medication list is important because there's an adverse effect of the medications. We need to identify it. And then interviewing witnesses. It's very important that we have an understanding of what happened. And I think we're all well aware that there are times the only history we get is what you provide as an EMS provider, and it could be hours, if not days, before somebody else shows up who gives additional information that adds anything to our workup. So if you talk to witnesses, get the information, describe or get their description of what happened and document it in your run report. So I think for me, if you have a patient with syncope, a lot of things that need to be done that have benefit in terms of completing the workup, we can do in the field. And for many of these items on the list, they are things that can change with time. So if you don't do it, it may result in more of a workup for the patient, or it may delay in the patient getting the definitive care they need. So that's what I have for December. I hope you have a good holiday and safe New Year's. If you have any questions, please post them on Workplace. Finally, the last thing I want to talk about related to geriatrics has to do with geriatric trauma triage. And what I have here is a listing of the differences between the geriatric and adult trauma triage criteria as defined by the state of Ohio. I don't have everything listed because everything else is similar. So I'm breaking out those 5 or 6 items that are different. So the first has to do with the definition of geriatric. For the state of Ohio, geriatric means any patient over age or 70 and above. An adult patient is anyone between the ages of 16 and 69. So the first one I have listed here is injury sustained in 2 or more body regions. That is unique to geriatric patients. So if they have a head injury and an abdominal injury, that's geriatric trauma triage. It needs to go to a trauma facility. This criterion is not listed for adults. So for adults, you don't need to consider how many body regions were injured. And I think in part it's because there's a thought that between the anatomic and the physiologic criteria, if an adult has a significant injury, you're going to find it based on those 2 different sets of criteria. There is a little bit difference in the GCS for patients. So if you have a geriatric patient with a GCS of 14 or less with a head injury, then they should go to a trauma facility. Or I think there's also the statement that if it's less than their baseline, so if their baseline is 13 and it's now 12, then they should go to a trauma facility. For adults, it's a little more liberal. It's a GCS of 13 or less. So there's a 1-point difference in terms of the accepted GCS for geriatrics versus adults. When you look at the systolic blood pressure, there's a 10-point difference. So in a geriatric patient, they are less tolerant of hypotension, and there are a lot of other things in place, such as cardiac disease and medications. So this, by the state rules, if a geriatric patient has a systolic blood pressure less than 100, then they need to go to a trauma facility. In the adult population, the threshold is 90 millimeters of mercury. If we're looking at long bones, there is a bit of a difference, both for adults and geriatrics. If there are fractures of 2 or more proximal long bones, meaning fractures of 2 or more humeri or 2 or more femoral or humeral fractures, I'll get it right, then they need to go to a trauma facility. But if a geriatric patient is in a motor vehicle accident and they have 1 proximal long bone fracture, that's enough to get them transported to a trauma facility. So it only has to do with MVCs where you have the requirement of 1 or more proximal long bones. Any other injuries where there's 2 or more long bones, it's identical between geriatric and adult. For pedestrians being struck, it's a mechanism of injury. It may be considered for adults as a mechanism of injury that would require transport to a trauma facility, but for a geriatric patient, if they are hit by a vehicle, they must go to a trauma facility. And the last difference in the criterion has to do with falling from any height. For a geriatric patient with a fall from any height, including falling from a standing position, if they have evidence of a brain injury or head injury, they need to go to a trauma facility. If you're talking about an adult, falls from any height, not a current criterion. So it's a little bit of a difference, but all of this is more conservative in terms of caring for geriatrics because they are more likely to suffer significant injuries and they are less likely to tolerate or survive significant injuries. Velocity of nerves, so the nerves slow down with time. Our basic basal metabolic rate drops with time almost by 20%, meaning we expend 20% less energy than when we were younger. Our cells have less water with them. Our cardiac index, our ability to pump blood, drops with time. That's even if you do not have underlying coronary artery disease. Our glomerular filtration rate, which is the ability of the kidneys to filter, goes down with time, and that's a component of aging. And when I talk with patients about our ability to filter, urine production is not the same thing as kidney function and our ability to filter out bad materials. So even though a patient's making plenty of urine, their kidney as a filter may not work as well as if they were younger. Our vital capacity drops with time. That's the ability of the lungs to fully exhale air and how much is exhaled, or how much we can exhale. So we cannot move as much air through our lungs as we would as a younger person. And our maximal breathing capacity also drops with time, meaning our lungs, as we age, may not be able to keep up with our metabolic needs. So breathing issues may prevent patients from being as active and as exercise tolerant as if they were younger.